Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. All my video lectures are mainly for educative purpose. In continuity with the previous lectures, that is examination of neurology or we call nervous system examination. Today we'll be dealing with the another cranial nerve, that is spinal accessory, that is 11th cranial nerve. Now this spinal accessory nerve supplies only two muscles, that is sternocleidomastoid and trapezius, but we'll be going through in detail. Anatomy, function, method of examination, interpretation and localization of lesion. Now if you see here, this particular spinal accessory nerve comes out from medulla. We have got two roots, one we call as a cranial root and one we call as a spinal root. Now cranial root comes out from medulla. As it comes out, it joins with what we call as a spinal nerve root, and that spinal root is coming from cervical segment, that is C1 to C5. So spinal nerve root from C1 to C5 forms a combined root together that will ascend up through foramen magnum, and after ascending up to foramen magnum, it will combine with cranial root. It will combine with cranial root here, and then it will come out through jugular foramen. Then it will come out to jugular foramen along with vagus nerve and glossopharyngeal. So glossop 9, 10th and 11th, three nerves will come out. But this spinal, we call spinal accessory, that is after combination of cranial and spinal nerve root, there will be some branches of vagus nerve. There will be communication. So cranial root diverges and joins the vagus nerve. So there will be one portion of cranial nerve root will be combining with vagus nerve and will be running along with vagus. So this portion. And the remaining part of that combined root we call spinal accessory nerve will come out. It will first supply sternocleidomastoid, and after supplying sternocleidomastoid, then it will supply trapezius muscle. This will be that. So cranial root motor to the muscles of pharynx and larynx, which travels with the vagus nerve, and spinal root will supply sternocleidomastoid and trapezius. So this cranial nerve root is giving nerve supply to pharyngeal muscle as well as laryngeal muscle, and it is traveling along with vagus nerve. We are not dealing that particular part. So we have got two things we call in medulla. We have got a nucleus ambiguous, and in a spinal we have got a spinal root for accessory nucleus. This is called accessory nucleus, and this is right from C1 to C5. C1 to C5, and it will ascend up. All these roots will combine together and it will ascend through foramen magnum, and after ascending it will combine with cranial root, will become a combined nerve. Then cranial root will get separated out, and that will run along with what we call as a vagus nerve, and then it will supply muscles of pharynx, larynx. While this is a spinal root portion, and after coming out to the jugular foramen, it will supply two muscles, sternocleidomastoid and trapezius. That's why this is indirectly a spinal root only, spinal nerve. But as it is ascending up and combining with the 11th cranial nerve, that's why it is a part of a accessory, spinal accessory nerve. So that is the way. And this particular root will be supplying muscles of larynx, and also via recurrent laryngeal nerve, it will be supplying the muscles of larynx, that is vocal cord, except cricothyroid. So this will be the supply, muscles of pharynx as well as larynx. So it will travel out and will supply sternocleidomastoid, and this will travel with what we call as a cranial root portion, will combine along with vagus, and then it will supply muscles of pharynx and larynx. So it innervates trapezius and sternocleidomastoid, and that will take part in movement of neck, head and shoulder. We'll be discussing that particular part. So after coming out, this spinal root portion will supply first sternocleidomastoid and then trapezius. And this one root, that is cranial root part, will be combining with vagus, and then it will be supplying muscles of pharynx, larynx, etc. So that portion we have already discussed. So this, after combining with vagus, muscles of palate, pharynx and larynx. So that is a cranial root part. And this combined nucleus, we call that as a nucleus ambiguous. And this spinal root part, after entering through the foramen magnum, combining with spinal accessory, again separates out after coming out to jugular foramen, and then it supplies sternocleidomastoid and trapezius, and that route is C1 to C5. So if you get the damage in the upper part of this, you will have a spinal accessory. This portion, spinal root portion, will be affected. Or if you get the damage at the level of foramen magnum, and if you get the damage in the jugular foramen, both portion will be affected. That is cranial root portion and spinal root portion, both will be affected. Because in jugular foramen, you got the 9th cranial nerve, 10th cranial nerve and 11th cranial nerve. All the 3 cranial nerves are coming out through jugular foramen, and you have got the internal jugular vein which is coming out. So already we have discussed that extracranial part and the coarse part of it, how it enters through the foramen magnum and then it comes out through the jugular foramen. So this portion already we have discussed, that after coming out through the foramen or a jugular foramen, then it will run in the posterior triangle, and then it will be supplying sternocleidomastoid and trapezius. So it has got 2 components, cranial component, spinal component. Cranial component supplies laryngeal muscles and pharyngeal muscles via vagus nerve, and after coming out through the foramen, jugular foramen, it will supply sternocleidomastoid and trapezius by a spinal component. So mainly we test for sternocleidomastoid and trapezius, which is helping the movement of the head and neck. So now supplied to sternocleidomastoid and trapezius. So we'll be dealing with individual now. So function, cranial root function is movement of soft palate except tensor veli palatine, pharynx except stylopharyngeus, and muscles of larynx except cricothyroid. So it is supplying soft palate, pharynx as well as larynx, and sternocleidomastoid and trapezius by spinal root. Now what is the action of sternocleidomastoid? Sternocleidomastoid, when only one side, say right side, contracts, it will turn the head to the opposite side and tilt the head, that is occipital part, towards that side shoulder. So it will turn the head to the opposite side. Unilateral contraction tilts the head to the same side and rotates the face, that is chin, towards the opposite side. When both are contracting, it will help in extension of the neck at atlanto-occipital joint, and it will flex the cervical vertebra so that the chin approaches the manubrium, that is manubrium sterni. So at atlantoaxial joint, it will help you to extend at the neck. And while working in the lower vertebra, it will help in flexion of the neck. So when you want to touch the chin, sternocleidomastoid will be working as a flexor. And when you want to extend the neck, it will be working also as an extensor. So extended superior cervical vertebra, if you extend your upper cervical vertebra while flexing the inferior vertebra, so chin is thrust forward with the head kept at the level. Also, during heavy breathing, particularly in case of a person with a respiratory distress, it will help to pull the thoracic part upward during deep inspiration, and that's why it is also called as accessory muscle of respiration. This will be the different action of sternocleidomastoid. So we'll be showing you that this is, ask the person to flex and you apply a little resistance on the forehead, you will see that both the sternocleidomastoid is becoming prominent. This will be one action, and then we'll be showing you different. So whenever you get the damage to sternocleidomastoid, you will see wasting in the sternocleidomastoid. You might see a fasciculation, particularly in a lower motor neuron type of palsy. Means if there is a damage outside the medulla, you will have lower motor neuron type of palsy either in the posterior cranial fossa or outside the jugular foramen. It will be a lower motor neuron type of palsy. You will have a little drooping of the shoulder. You push the face to the opposite side and you apply the pressure by the palm, and the opposite side sternocleidomastoid will become prominent. So if suppose you are testing for the right, ask the person to move the head towards left side against the pressure. You will see the right side sternocleidomastoid is becoming prominent. If this movement is affected, that side sternocleidomastoid is damaged. Function is poor. And when you ask the person to shrug the shoulder against the pressure, you are testing for trapezius muscle. So in upper motor neuron, ipsilateral sternomastoid and contralateral trapezius wasting. Ipsilateral sternomastoid and contralateral trapezius wasting. And in lower motor neuron, ipsilateral sternomastoid and trapezius wasting will be there. In upper motor neuron, contralateral trapezius wasting. Sorry, there is something wrong. So ask the person to rotate the head to the opposite side while applying a resistance. You can see here. Here you are applying a resistance to the left side and person is trying to rotate to the left side. So you are testing right sternocleidomastoid. Here also you are doing the same thing. You are testing the right sternocleidomastoid. You can see the right sternocleidomastoid is becoming prominent. So this sternocleidomastoid is working. So also there will be tilting of the head backward. This particular action you can test for sternocleidomastoid. When both are acting together, the head is tilted back, but you ask the person to flex the head against the resistance applied at the forehead. We have already shown you here. You will be testing both the sternocleidomastoid. And you can see that both sternocleidomastoid has become prominent as accessory muscle of respiration in a person with COPD or status asthmaticus. Now, while doing this particular test, you can look for the prominence of the muscle, look at the tone during action of the muscle against resistance. So this will be testing for sternocleidomastoid. You can see here, this sternocleidomastoid is becoming prominent. Now here the person is rotating the head to the right side. So left sternocleidomastoid will be becoming prominent. Here, head is turned to the left side. So right is becoming prominent. Here person is turning the head towards the right side. So left sternocleidomastoid is becoming prominent. Here again you are asking a person to rotate the head towards right side. So you are looking for left sternocleidomastoid. So that is how you look for. While looking at the trapezius, for contraction of the upper fiber, you are asking the person to lift the shoulder up against the resistance. And while lower fiber, you are applying the hand in the axilla and asking the person to depress the shoulder. And for middle fiber, you apply the pressure on the two scapula and ask him to retract back. These are the three actions: elevation, depression, and backward movements. So this three action will be tested for trapezius muscle. Here you are testing for the upper fibers. These are all for upper fibers. Here you can see these are for upper fibers. Asking the person to lift the shoulder up. Either you stand behind the person or you stand in front of the person and do. Best is by standing behind the person. That is a better way. This is better. Or you can do even by standing in front. So if trapezius muscle is affected, these movements will be affected. So elevation, depression, and retraction of scapula, they will be affected. You will have a wasting of the muscle and shoulder will be drooping down. This will be very common. And single muscle affection is usually outside the jugular foramen. And if only trapezius is affected, the nerve after supplying sternocleidomastoid, that portion must be affected. When both are affected, it is usually after the jugular foramen. So you are looking for the sternocleidomastoid action movements. Sorry, this video is not working. Otherwise, we could have seen that particular action. Now you can see that first it supplies sternocleidomastoid and then it supplies trapezius muscle. Again, this particular is not working. So these are the two muscles which are being checked. While you want to test the spinal part, you are doing for trapezius and sternocleidomastoid. And if you want to look for cranial portion, the most simple test is asking the person to swallow. One simple test. And another test you will have to test for gag reflex. You will have to test for looking at the arches, etc., which is a part we have already discussed in 9th and 10th cranial nerve. So clinical finding in paralysis of sternocleidomastoid and trapezius muscle, drooping of the shoulder, inability to turn the chin to the opposite side, inability to draw the head forward, and you will have also inability to lift the shoulder up, shrug down, and retract back. You can see here this side shoulder is drooping down. So there must be involvement of trapezius muscle. And whenever there is an irritation of nerve, you will get spasm of the sternocleidomastoid producing torticollis, or we call wry neck. And once in a while, a penetrating injury in the posterior triangle can produce a damage and will produce the functional loss of trapezius and sternocleidomastoid. So it will produce weakness or paralysis of sternocleidomastoid and trapezius muscle. Trapezius muscle dysfunction will produce the drooping of the shoulder. arm movement, particularly upward movement, downward movements, and backward. And you will get a prominence of scapula, we call wing scapula. That will be very peculiar. And patient will also experience the shoulder and neck pain and muscle fatigue. That will be quite common. So atrophy of trapezius muscle, drooping of shoulder, difficulty in abduction of upper limb above the horizontal level. Normal prominence of the neck produced by the trapezius is also reduced. So that will be drooping of the shoulder. And due to irritation, you can get torticollis, that is also we call as a dystonia, asymmetrical shoulder, and impaired arm elevation. This will be in irritation of spinal part of 11th cranial nerve. So damage to the left branch of spinal accessory. This person at rest and normal tension from right sternocleidomastoid is providing a neck to turn to the opposite side. We call as a wry neck, or we call as a torticollis, and this is also disorder that is called dystonia. In dystonia, you can see that this type of movement can be seen in a dystonic disorders. This is wry neck. It can be in irritative lesions or it can be sometime habitual also. Also, you can have bilateral lower motor neuron palsy because of Guillain-Barré syndrome, motor neuron disease, poliomyelitis, we call bulbar poliomyelitis, severe polyneuropathy, particularly very frequently seen in a Guillain-Barré, or also sometimes you can have involvement of those by botulism, etc. Or you can get a damage to the nerve because of damage in the posterior triangle or outside the skull, or compression by tumors at the jugular foramen, and very rare we call as a syringobulbia. In that you can have a damage to the cranial nerves, and that will produce lower motor neuron type of palsy. So this will be producing lower motor neuron type of palsy involving multiple cranial nerves, not only 11 cranial nerve, maybe along with 9, 10 also. So unilateral is very common in traumatic injury in the neck or at the base of the skull near jugular foramen, jugular vein thrombosis, tumor in the jugular foramen region, jugular vein thrombosis, bulbar poliomyelitis, syringobulbia, while doing a surgery in the posterior triangle. Good number of times you see also a damage to spinal accessory during forceps delivery, but the days of forceps delivery are gone. Bilateral damage will be more common with bulbar poliomyelitis, motor neuron disease, Guillain-Barré. Also in case of syringobulbia, you can have a bilateral damage, and you can have involvement of muscles only in muscular dystrophy. So shoulder muscle dystrophy can produce an involvement of those muscles, but which will not be due to spinal accessory. So unilateral lesions quite common at jugular foramen, and bilateral lesions, motor neuron disease, and we should not forget involvement of the muscle, neck muscle as well as shoulder muscle in case of limb girdle myopathy. Particularly during surgical procedures in posterior triangle, you can have a spinal accessory muscle, spinal nerve damage, producing palsy of spinal parts. During difficult delivery, particularly forceps delivery, and compression at the jugular foramen, we have already mentioned, that is jugular thrombosis, internal jugular thrombosis, or as due to tumors. Occasionally penetrating injury, surgical intervention, you can go for reanastomosis or you can go for nerve grafting. So I end my lecture here. Thank you very much for taking out time. I know that your time is valuable and I appreciate that for spending some of the time with me. If you feel this lecture is helpful to you, please don't forget to press button like, subscribe, and you can share with your friends also. See you in next lecture.